Small round of applause, but that's all right. We'll get you guys warmed up. For those that weren't there last night, really quick introductions. I'm Quentin. We've got Dylan at the front here, and together we started EMS conferences back in 2016. And we're paramedics from Perth and just wanted to go snowboarding every year and saw a few other conferences running and thought, why can't we do that? And so we just want to, I guess, start by just really just showing our appreciation for everyone that's here in the room tonight. The vast majority of the people that are coming, not just attendees but also presenters, have actually been to a previous conference before or were directly recommended by a friend. So it means so much to us that everyone who's coming back again or who go back and let their mates know about what we do over here. So thank you very much. Good news is you don't have to hear me talk much during the week. So we've got 10 amazing presenters. Really the idea behind these conferences is to keep the sessions short and sharp so you can get out and enjoy yourselves. So hopefully that's what you guys are all doing. Being the first day, I probably am going to talk a little bit more, just to let you guys know some exciting things like how to win prizes, a bit of the schedule for the week, about the workshop tomorrow. But as the week goes, that will slowly die down. We'll kind of be get you guys in, have some tea, coffee, listen to some awesome presentations, get you guys back out again and enjoying yourselves. General structure for all our sessions is that we will have our afternoon tea or a tea with coffee out at the start, so that when you come in you can grab something. If there's stuff left over, it will certainly be up there for the small break we have between presenters. But if you do need to get up, stretch your legs at any stage, please feel free to help yourself to the tea and coffee station, which will remain open for the entirety of the session. We've got a question already right in the back. The mic's not loud enough. All right, Dylan's onto it, that's all good. And I guess on that, it's a great segue to my next one. If you're at the back and you're struggling to see the screens, we do have lots of seats available at the front. So if you're feeling brave, come down to the front. I can't promise you won't get picked on to questions, but I reckon you've got a good chance of that you should be all good. So, is that a bit better? Yeah. Awesome. Now they've got the sound right, you can hear. I think it's a good time to pull up our first presenter of the evening. Let's make him feel really welcome. He's already presented 2 times for us, so this is lucky number 3. Let's hear it for Mark Corden.
Hi everyone, thanks for coming out. Thanks again to Quentin and Dylan for inviting me back. It's an absolute delight to come to Queenstown, have a break, not from my family this time, they've come with me, but they're not here tonight, so I can say that. For those at the back, especially for one standing, literally seats. I feel there's a gulf between all of us right now. It's called the first 4 rows. So this talk is 80% of acute paediatrics in 50 minutes. When I first chatted to Quentin about presenting at these conferences, and he described them to me, and about a third of the audience are doctors, nurses and paramedics, I was initially quite worried about where to pitch the talk, what to talk about, and essentially, from what my experience, if you don't work with children day in, day out, as a healthcare provider, you're generally shit scared of kids. So that's what this is. Last year I gave a talk on what kills children and how not to do it. And that was a talk basically on the fundamental approach to kids, and these are just the fundamentals in paediatric medicine. So, a quick introduction, who the hell am I and why should you bother listening to me? You don't have to. But I'm Mark Corden, I'm a paediatric emergency medicine specialist. I am a member of the College of Physicians, a paediatrician by trade, and there are generally 2 basic species. Is that a question? Still not loud enough. That sounds like an invitation to come right up front. Not taken, okay. So there are 2 basic species of paediatric emergency medicine specialists. There's the paediatricians who do a bit more time in emergency medicine and intensive care, and then there's the emergency medicine mob who do a bit more time in general paediatrics. So I'm the general paediatric version of a PEM, which means although I can put a central line in, I'm more happy talking to you about your child's consultation for 30 minutes. The ASIMs like to do it the other way around. I'm an associate lecturer at the University of Melbourne. I do write some quizzes, not the intelligent stuff, just the quizzes for Life in the Fast Lane. I work at the Northern Hospital, which is an outer metro hospital in Melbourne. It's the busiest ED in Victoria, the generally second busiest ED in Australia. We usually battle with Fiona Stanley for the right of being the second busiest. and I've got 3 kids myself. Anyone at the drinks last night would have seen they're all a bit older than this. This was the last time we had a decent looking family photo. So it's a few years old now because it hasn't looked that good since. All right, so what are we going to really talk about today? Just literally the stuff that if you were going to see a kid, by and large, this is what you're going to have in front of you. One of the main presentations, 80% of what I do, for me it's rote learning. If you're not doing it every day, then it's a bit harder. So this is what I want to basically talk about. When we can do it with evidence-based, perfect, brilliant. We should be doing evidence-based medicine when possible. But to get a good evidence base, you need common conditions, common therapies, any of the weird stuff. We try and work from first principles, basic physiology. Am I going in and out a lot? Reverb's a bit rough. No? Thanks. And if we can't work on evidence-based, we'll discuss where and why. We'll talk about the cynical approach to evidence-based medicine. We'll not spend too much time on that because that can be dull. And we just want, basically, as much as possible, everyone comfortable with good quality basic acute paediatrics. So if you have a sick kid, what are you going to do with it? And this is not going to be one of those, tomorrow's talk I'm talking about communication, that would be a TED-style talk, the 3 basic things and lessons I want you to take home with you. This is not that talk. This is a bit denser, and if anyone wants all of the slides here with the speaker's notes, everything referenced, it's yours. So you can, I've got business cards out the front. My wife took the piss out of me because they don't business cards with that QR code, so you actually got to type in my email address. But if you want them, if you want anything on this talk, it's yours. Like, I'm not precious about the slides. I'm happy that they go out and get used if you find them useful. Okay. So, I have a lot of respect for my ambulance colleagues, so I would never do this. I was raised by a nurse, so I would never pick on a nurse as well. Are there any residents or registrars in the room? Meek, show of hands. Beautiful. Up front, that is excellent. Okay, so the last principle of this talk is that wine is good. To the residents and registrars, but to anybody else who wants to play, everybody else is free to play this game. You know how consultants always have those really obnoxious, massively esoteric questions that they love to ask you? You've got no fucking chance of answering it correctly. Do they do that? Right, let's do that. But with the promise of wine at the end. So, in this room, no phones. No phones. Term PRN. We have been prescribing and dispensing medicines, PRN, collectively in this room for over 1,000 years, easily. To whoever wants the first bottle of wine, this is my favourite obnoxious question. My second favourite obnoxious question is at the end of this talk. What does PRN actually stand for? Oh, hello, pro renata. Very good, very few people ever get that. What does that mean? You've got the wine, done. Pro renata. That's not the literal translation, though. Pro renata, it is pro renata. Very few people ever get that, so well done. And there was another one over here. Pro renata literally translates to as a thing is born in Latin. So the figurative translation is as is needed. So perfect, an excellent start. Okay, so let's take this excellence and keep on going. Thank you. So this is not a talk on the really hard stuff, each of the topics like arrest, major trauma, status epilepticus, they need their own talks. They need an entire hour minimum per. And the really simple stuff of runny noses and coughs and colds, you know, Auntie Donna can do all that sort of stuff. This is the main stuff in the middle. So the main stuff is basically going to be all the coughs and colds and all the consequences of respiratory infections that kids get, the giants, which are the main topics that we talk about a lot of the time that do require a little bit of attention, and then the fact that kids are idiots and fall off everything and have minor trauma all the time. But again, it's not major trauma, it's minor trauma. All right, so we're going to do cough. I know I've just said we're not going to do simplistic stuff, but cough is so common and can have a couple of traps. We're going to do cough. Asthma, bronchiolitis, and croup. Some tricks, some traps, and again, everything you want, you can take home with you. All right, so basic cough. You know, it's about 5% of easily walks through a paediatric ED's door. Now, most coughs are just intercurrent viral infections. We're going through a ton of flu, a ton of RSV, a ton of paraflu, all the standard viruses at the moment. But 90% of these coughs are absolutely going to be fine and resolve in 1 to 3 weeks. Of course, from a paediatrician's point of view, prescribing amoxil or steroids for cough is a cardinal sin. But there's pressure in the community to get these things. So not too judgmental, just die a little inside. Post-viral coughs can be real shits. They can last for up to 12 weeks. And these are the families that you have in front of you, and they're desperate. The kids aren't sleeping very well. The parents certainly are not sleeping at all well because the kid is coughing at night time and everyone's losing their mind and they're begging you for amoxil and steroids to make this go away. They will also have tried every cough syrup and cough medicine over the counter that is possible to purchase. Officially, we do not recommend cough medicines under the age of 6 because of course they do 5/8 of bugger all, but also they can have problems with them. 100 years ago that was probably less true. If you have a cough syrup that's full of chloroform, morphine, cannabis and alcohol, that probably did stop your cough, but it's not highly recommended. And you might think this is just 100 years old. In 2021, I think it was, Infant's Friend, which is not a cough syrup, it's a colic formula, had a recall for too high concentrations of formaldehyde in it. So it's not just history, it's history repeating itself, unfortunately. So when the parents come in desperate with the post-viral cough, there is one thing to know about that. The classic post-viral cough is that dry, hacking cough, always worse in the evening and night time. Everyone's sleep is shot up against the wall and splattered everywhere. But what if it's not post-viral cough? What are the other options? One of the main options is this thing called PBB, persistent bacterial bronchitis. You don't have to know too much about that. Think of it like a bacterial overgrowth syndrome in the bronchus. So 50 years ago we thought the bronchus was a sterile environment, had no bugs. We know of course there's commensal bacteria in every part of your body basically. Certainly in this nice, wet, warm and aerated environment. So of course we've got staph and threps living in our bronchus, generally in equilibrium, the old-fashioned word commensal. But if you've got a cough and a cold, everything is rough and raw and ready, the natural sheen, usually I'm pointing to a wall instead of this. So if no one's looking at me, it absolutely makes sense. I would be looking at that too if I was sitting where you are. But the normal white sheen wall of your respiratory endothelium is of course cracked and red and raw and swollen and shit. So of course bugs can come in and just set up shop and have a bacterial overgrowth. So this chronic cough, which can be up to 10% of cases of chronic cough in kids, so it's worthwhile thinking about, is generally a wetter, barkier, horrible, deeper, all the live long day sort of cough, no real diurnal variation. And that's a cough that, yes, it can be fixed by 10 days of augmentin. Steroids, of course, still do bugger all. Then there's the last cough, the 100 days cough, which I usually ask questions for, but I haven't got wine for that one, so I'll just give the answer. It's, of course, whooping cough. Pertussis. Now, whooping cough is, we won't spend too much time on this one. It's the standard, you go about 2 weeks of the standard runny nose and cough, and then you get to the whooping cough. The whooping cough, the hoop for whooping cough comes from the paroxysm of coughing, that intense cough the kid cannot control. And it's like cough, 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 cough. The hoop is that massive inhalation at the end. So for a little baby who hasn't got enough musculature to hoop, it's still going to be whooping cough. This, of course, we would like to see less of. There's more vaccine hesitancy. We're seeing more and more of pertussis. Also, the vaccine wanes over like 8 to 12 years, and the vaccine that we use these days is not as effective as it was as the one we used to use. The con of the one we used to use was it actually had the small risk of giving you pertussis, hence we changed. A pertussis won't kill a 2-year-old. It will just make your life horrible for 100 days, but pertussis can kill a baby, a 1 to 3 month old, very easily. So it's still worthwhile promoting vaccination, having a chat to colleagues and keeping an eye out for sick contacts when you're seeing a small kid with cough. Are there any outbreaks in the local area? Anyone sick at home? Also, I should say, if anyone wants to stop any time and ask questions or get the microphone at the back to be raised up again, please, I love questions, I love being interrupted. All right, so probably the most common thing we're going to see, especially in each time, is asthma. I mean, we all know a lot about asthma, but what are the things that we want to know specifically with kids? When a registrar is trying to talk to me about asthma, one of the things I really know, if they present these parts of their history to me, I know they know about it in kids and they've thought about it, especially in this kid. The background of the kid. Have they ever been to ICU? Have they ever required IV therapy, magnesium, aminophylline, IV steroids, these sorts of things? These are the 2 major red flags. If a kid hasn't needed any of those things, you don't get to sit on your hands, but you can have a breath yourself. And that's a damn sight easier. Otherwise, things to know at home, you know, is there passive smoking at home? Is everybody in the home sick? Of course, the main trigger for worsening asthma is having a cold. If the kiddie is sort of 1 to 2 to 3 and they've had a couple of episodes, we often don't call it asthma, we call it viral-induced wheezing. The pathophysiology is exactly the same thing. The symptoms, yes, they're obvious. They're coughing, they're wheezing, they often are short of breath, and they do have a lot of chest tightness. Even the kids, they can, you know, the adults will go, I feel tight in the chest, or they're doing that hand thing when they're feeling tight in the chest, or they're having a heart attack. Nothing about here is about coronary syndrome today. I don't know anything about shipping. But they still do feel tight in the chest. The trick with wheezing, for people who really start examining kids, obviously wheeze is expiratory. It's that classic expiratory polyphonic. And I do recommend taking that half a second every time you've got your stethoscope on an adult or a kid. I assume you see adults. Again, I don't have to worry about that. Have a listen to the quality of the wheeze. How to tell how bad the wheeze is in kids. The worst is obviously no wheeze at all, silent chest. They're not even moving enough air because they're so tight to make noise. Oh, they're not wheezing, brilliant. You know, they're not breathing. But that is a common mistake. So the worst wheeze, when there is wheeze, is that pan-expiratory from the start to the end of expiration. That's the worst. Then mid to end is not as bad, and the little squeak at the end is pretty fine. And the other calibre of wheeze, the main hallmark, which it is worth thinking about every time we listen to somebody, is it polyphonic or monophonic? Is it polyphonic? You have multiple tones, that classic, because the respiratory tree is multiple branches, multiple size tubes, giving you multiple tones. So a good wheeze will have multiple tones, beautiful musical notes to it if you want to get lyrical, versus a monotonic, terrible whistle, sorry, a single note, which would mean a single compression or obstruction to a single tube, which is not the diffuse pathophysiology of asthma. It's a single tube. It's most likely a tumour. Once in a blue moon, we get this story. Kid presents with wheeze, you've got some wheeze, get some steroids. It was never wheeze, it was a tumour. A T-cell lymphoma, a thymoma, something in the chest. Steroids are antineoplastic. They do shrink that bloody tumour, wheeze goes away. All winning. Then, of course, the tumour comes back, wheeze is back, chest x-ray, shit. But now, the tumour has already been treated with a chemotherapeutic agent, a steroid, and the easiest time to treat a tumour is the first time, not the second. All right. So, this is a terrible slide, don't look at it too much. Asthma can be quite complicated, so let's take the complication out of it. This is the Queensland guidelines. I chose it because it fits on one slide. All right, what's the basics? Now, I don't want to insult anyone by talking about something if you want, but there are a couple of traps in paediatric asthma that are worth talking about. The first is that we talk about bursting kids. You know, if they've got a wheeze, I should burst them. But in New South Wales, they call it stacking. The burst is the classic. We've switched to EMR, thankfully, my ancient poverty-ridden hospital, but we have EMR now, so this is an old paper chart. The burst is the 6 puffs if you're under 6, or the 12 puffs if you're over 6 of salbutamol at 0, at 20, and at 40 minutes. And the reason I'm talking about this is a lot of my trainees come in thinking, oh, the kid's wheezing, I have to burst them. If your kid's wheezing, yes, they need some bronchodilators, but they don't need the full burst. What if they're better after the first 6 puffs? They don't need it. Why would you give medicine to a kid who doesn't need it? What if they're better after the second 6 puffs? Then again, they don't need it. But you can see a lot of people give a lot of Ventolin, and so this idea becomes, oh, I've seen 5 other kids bursted by people who have got grey hairs and older than me, so I should do the same. No, you can give bronchodilators. If a kid is sick enough to need all 3 doses, yeah, yes, they have been bursted. Why am I really bothering? Is 6 puffs a problem? No. But if they get the full burst, suddenly they're locked into the stretch, which is the discharge criterion. They need to basically not need Ventolin for 3 hours between doses before we can really safely let them home. But if they were better after 2, they weren't bursted. They don't need to be stretched. You haven't taken all this extra time from this family and all these extra bed pressures on your hospital. So that's the main trick with Ventolin. Often kids will just, especially the younger kids, their first presentations, they're quite mild. They only need 1 or 2 goes of 6 puffs. Another question might be, how young can I give Ventolin to? When I was a young doctor, when I was healthy and had a full better hair and I could sit like that without getting too sick and sore. The teaching was that kids don't develop beta-2 receptors in their lungs until about 9 months of life. We know that's not technically true now. The studies on neonates have shown that they can actually have changes to their respiratory physiology with Ventolin and not. So I got thinking, why did that knowledge ever pretend to exist? I think it's because we don't really get clinically meaningful changes until a kid is about 9 months of life. So from 9 months, I'll happily try some Ventolin to see if it helps. Only 6 puffs, never a full burst. From 12 months, I'll try it with far more expectation of benefit in the kiddo who's wheezing, because the younger kiddos who are wheezing will probably just have bronchitis. Okay. A lot of kids will get bursted with both. Both is Ventolin and Acute. Acute is an for all those doing their ASM exams, anticholinergic, bronchodilator. It does work in a different mechanism to Ventolin. But how much does it work? The short answer is it actually works quite well. It is a bronchodilator. But we don't have to use it very often. A couple of iterations of the Victorian asthma guidelines, it didn't appear until severe. So it appeared on the guideline when you were reaching for IV stuff. IV magnesium, IV everything. But now we use it quite a lot. Arguably, I would argue, too much. When do we use it? There was a study in Perth, where these chaps are from, that looked at Acute in mild to moderate asthma and showed that it didn't add benefit. No reduced ideal length of stay, no reduced rates of admission, all of that. So mild to moderate, it didn't work meaningfully. But it is a bronchodilator. So it does work in severe. So when do you use it? Because the kids also, has anyone ever tried it? It's rubbish. Have you heard how bad Fluclox syrup tastes? Once tasted, never prescribed. If you ever have Acuvant open, just have 1 puff. It's terrible. So you have a little kid, 2-year-old, give 6 puffs of Ventolin, they can't love it because there's a mask on their face is this big. The mask is this big, it's shit house for them. But they tolerate it. And then you give them 4 puffs of Acuvant, and they're finding pissing it off. So the next time you give them Ventolin, they're going to hate you. Plus, they get nauseated, plus they can vomit. So when do you use it? You're really going to use it when. So when, for me, there's 3 contexts. The first is severe to critical asthma. I'm reaching for IV, I'm reaching for everything, I'm reaching for oxygen, so I'm going to reach for that too. The second option, which is the lesser evidence-based, but I'm still happy to put my name on it, or just put my hand up to it, is that the kid is almost severe, as in, I'm going to put some numbing cream on them in case I have to drip them in an hour to give them all the IV stuff, but I'm hopeful that in the next hour they will improve enough that I don't have to do it. So I'm thinking I might be severe, but I'm going to work on it. So in that context, sure, it's not very invasive, it's not a needle, so it's a bit easy to do it. And the third one is when you really need Ventolin sparing agents. What's that context? That's the kid who comes out 8 in the morning, the parents have been doing their best, and that means they've been giving the kid Ventolin every half an hour since midnight. So the risk of salbutamol toxicity is really high. And in this kiddo, I'm whacking them with steroids, we'll talk about that, and I'm whacking them with Acuvant to try and reduce the need for Ventolin, because Ventolin still works, even though you can become toxic from it. So, let's talk about steroids and asthma. Anyone who goes near a paediatrician will know to never prescribe antibiotics to a UTI without a urine specimen, and they'll know never just to flippantly mention steroids, because that's how we have apoplexy. But I have an opinion on steroids, I'm going to share it with you. It differs to the state Victorian opinion, so I'm going to really go backwards and just kind of explain why I have my opinion. To do that, we're going to talk about the principles of medical literature review. Medical literature review, we do it to make ourselves feel better. You know, cynically. This is the cynical part of the talk. You have an opinion, you have a bias, you have a thought. You do a quick PubMed search, you find an article that agrees with you, brilliant. I always knew I was right, I always knew I was a genius. You find an article that doesn't agree with you, shit. What do? You keep reading. You find any single flaw in that article, a spelling mistake, a punctuation error, ideally a methodological flaw, and you go, oh, well, that article doesn't matter, so I'm still a genius. And this is kind of where we get to with steroids in asthma in kids. So, in 60 seconds. It basically starts in 2009 with this person called Paediatric. It was a decently done study. Prospective, the best kind. Double-blinded, Excellent, randomised control, perfect. Study of placebo versus PrEP. But this doesn't agree with me because I like steroids, and this article said steroids don't work. So how do I find a flaw in the article? The inclusion criteria had kids down to 10 months. So a lot of kids who probably just have bronch, and we're never going to respond to any of these things that try and help us with our asthma. All right, moving forward. Steve Foster, altogether brilliant but mad as a cut snake Scotsman working in Perth several years ago, did a decent article, again, prospective, double-blind, randomised control, on steroids versus placebo in asthma, but his inclusion criteria were 2 years to 6 years, not the extra little babies. He did this article to prove Paediatric right, because all in that time we were walking around going, we're paediatric trainers, I was a reg at the time, we know better, we know not to give steroids, aren't we smart? Proved him wrong. It was one of those great articles that was a complete backflip, surprised by the results, less ED times, less rates of admission. It actually really worked. And table 2, which is always the adverse events table, no real differences in, hyperphagia, they hear about a house home, they go crazy at midnight sort of thing. No, the rates of weird behaviour, excited behaviour, hyperphagia, everything was the same in the two groups. So no real difference, but benefit from asthma. So this was practice changing, but not for everybody, because of course it takes a long time to change practice. Is it just PrEP? No. Dex works really well. And for a good couple of years, this confused the shit out of me. Because one dose of Dex is apparently similar to 3 days of PrEP. Now yes, dexamethasone has a longer half-life than PrEP, but 3 days longer? No chance. So it never made any bloody sense until we come to New Zealand. Wallace, 2021, did another study. Again, the right kind, prospective, double-blind, randomised control, all really good stuff, and looked at steroid versus weeks, 2 to 6, the same one. And where do we get to? We get the issue where bias wins. If you are a doctor who has grown up with Paediatric and you don't like steroids, you read the conclusion. Prednisone does not alter outcomes of respiratory at 24 hours. I always knew it. I was right. I'm amazing. But if you're like me, you're like, well shit, that doesn't agree, I'm going to keep going. You go, hang on, but if you really read the article, admission rates, ongoing steroids, and need for IV therapy were improved. So where the hell do we end up? I think this, to me, makes everything make sense. Why is 1 day of Dex the same as 3 days of PrEP? Because it's only the first day that matters. So the primary outcome in the Wallace article, for example, was Wheeze score, which is like an objectified way of measuring Wheeze at 24 hours. So steroids got you through to the 24 hours, most safely, and then after that, no real benefit. So my colleagues and I at the moment, we give 1 day of PrEP, 1 dose, and we're done. Much, much happier. And I would advocate for that. That is against the current state Victorian guidelines. You'll be aware of that. I'm happy to stand up here and say it, but that's where we get to. So that's steroids in asthma. That's ventilator asthma, that's adjuvant in asthma. But because it's the common talk, we're not going to do IV stuff in asthma because that's a bit too severe. That's a bit intense. Any questions about asthma, kids, coughs, giving cough? Cool. All right. Croup. Another ridiculous. Anyone on the evening shift or the night shift in an ambulance will see a metric shift time of croup on the language. Okay, croup, 3% of kids per year. Absolutely. About 70% of cases are paraflu. It's one of those ones we have to teach our kids. What's bronchiolitis? RSV. So what's croup? Parainfluenza. So it's one of those real basics. We like to think of croup as a one-night illness. They croup, we give them some Dex, they go home, stop thinking about it, but it can go for up to 9 days. It can be a real lasting disease. Very, very, very rare. The croup can be so severe, you've got to intubate them. If we do it badly because their airway's buggered, then they can arrest. But what's the trick with croup? The trick with croup, the one main trick, is that you have to treat it like Rumpelstiltskin. You've got to call it by its name. And then everything else makes sense. It is viral laryngotracheobronchitis. So it's a viral infection. Instead of the man flu, the runny nose, the cough, the sore throat, ears, and not the pneumonitis, it's the middle. So it's this, and this. And now it all makes sense why we have croup o'clock. The kid is mildly viral, maybe have a runny nose, may have no symptoms whatsoever, and then they go to bed, and whilst the inflammation, the edema, is building up in this bit of their airway, then they wake up and breathing is different to how they were when they back to bed. And so they wake up with that air hunger, and they're breathing really hard to try and get air in past this now swollen tube. And so they have that stridor and that, sorry, I didn't have the microphone usually, that barking cough. So laryngotracheobronchitis, that's what croup is. If you just call it croup, you've got to remember all these facts and figures. If you just call it by its real name, you don't remember shit. It all makes bloody sense. So, what do we go? How do we treat croup? We just croup. Dex, good old-fashioned Dex. Same for asthma now, same for croup. There were a whole bunch of studies which have different protocols. Some use 0.15 per kilo of Dex, some use 6 per kilo of Dex, some use 0.3 per kilo of Dex. No study has been done that shows that compares lower to higher dose. We just know that it works at somewhere in that dose range. So the Victorian guidelines have gone, well, if some is good, then more is better. And it said if it's mild to moderate croup, just use 0.15. If it's severe croup, if it's severe croup, use 0.6, but that is the least evidence-based part of croup. That we're using Dex for croup is brilliant. If you don't have the time for Dex, because Dex of course will take a minimum of 90 minutes to really begin to work, and has peak effect of 4 hours, and this kid is striving and working hard to breathe at rest, then you need to do something now. Of course, the now is nebulized through 5 mils of 1 to 1,000, throw it at them. Very, very safe. And it will completely give you a lot of time. You might need a second or a third neb to get to when the steroids are kicking in, and that's okay. The other thing with croup is minimal handling. You do not want to upset the child too much because they've only got so much of an airway. So give them a bit of medicine and run the hell away. Come back in a little bit. One of the main things I like to think about if it's not croup, because basically we are talking about laryngotracheobronchitis, but we're also talking about an upper airway obstruction. So if it's not croup, the main things to think about are, firstly, quick history, are they immunised or not? Great, that rules out diphtheria and roughly epiglottitis. If you were in 17th century France, what we call croup today, they call false croup, because true croup was diphtheria. That's true croup in ancient medical history when I was born. In how a foreign body is always a good thing. Was there a history of quick choke? Is a 3-year-old throwing Lego into the cot for the 1-year-old to play with? That's a good one. But the main one, if it's not croup, it's bacterial tracheitis. So not viral laryngotracheobronchitis, just bacterial tracheitis. The kids are supposed to look sicker, but we usually see them early, so they don't. But they might have an absence of viral features, they might be a bit more pain, a bit less neck movement, and they often won't fit the story. We talked a lot about story the last time I got the chance to speak here. The story of croup. I won't talk about stories, I love talking about it, this is about content, not story. Is the age range, usually 6 months to 6 years, peak age 18 to 24 months, same age range as for febrile finger seizures. So if the story doesn't fit, so the kid hasn't come in at midnight, croup clot, mild viral features, classic barking cough, and he's the right age, if all those ducks line up, and 95% of the time those ducks do line up, then that's going to be croup. The more times the story doesn't fit, the more thought you have to give to what if it's not? And that's the main truth. Call croup by its real name, and then if the story doesn't fit, you have to think of the other things in an upper airway issue. Alright. The other main thing for peds, again, yes mate?
Sorry, with regards to the adrenaline, is there some like I would just say, with regards to the behaviour assessment, or is it just the way it works?
So the question is, if they're under 9 months, how do we affect adrenaline to help? So the main reason why laryngotracheobronchitis is going to cause, it's not a beta agonist, it's not a viral, it's not a muscle tightness, it's an edema issue. It's swelling of the airway. So steroids slowly improve swelling. Adrenaline nebulized very rapidly affects the vasculature, so it's not got nothing to do with beta-2. It's going to affect vasculature generally, alpha-1, alpha-2, beta-1, beta-2, to improve edema. Thankfully, that sort of croup is rare in the younger kids, but it's not impossible, and nebulized adrenaline will still work. But that's a perfect question. All right, bronch. So if croup is basically Rumpelstiltskin, bronchiolitis is a giant, immovable monolith. It is just there. thing with bronchiolitis that I would impress is that bronch is bronch. Almost nothing changes bronch. And everything's been tried in bronch. So how do you approach that with the kid? With bronchiolitis, you look at the three main pathophysiology. You've got a normal airway, and then it's infected. A bronchiolitis is just man flu that's gone rogue. It's gone south. The way I explain to parents, the way I explain to myself, is you've got all the swelling of man flu. You've got the edema, the pain, the redness. Take that from man flu and chuck it in your lungs, and that's what the baby has got to breathe against. And that's where you get your problems, and that's where you can focus your attention. So again, what's bronchiolitis? RSV is one of the really common ones. You just have to basically, my trainees just have to be able to parrot that. What can RSV do if it's not just bronch? It can cause apnea, profound apnea. The baby can pause their breathing and basically stop their breathing until they get hypoxic damage. When is that most likely? Prematurity, age less than 10 weeks, or any pre-existing heart or lung disease. Again, it makes sense. If you're a 10-week-old kid, you're going to be hit by a bronch less than if you're a 6-month-old kid, and less than if you're you're going to be hit harder at 10 weeks, less hard at 6 months, less hard at 12 months. It's a disease of the first year of life. How do you measure it? How do you measure bronch? Two ways. The first is severity. Is it mild, moderate, severe? Every respiratory condition we have, we measure. Is it mild asthma, moderate asthma, severe asthma, mild group, monogroup, severe group? All the respiratory shit in paediatrics, we just go to mild, moderate, severe, with the one exclusion that asthma has an extra branch of critical, which is fair. I actually find the mild, moderate, severe good. I find it excellent, not just to discuss to myself when I'm thinking my patients through in my head, not when I'm communicating with my colleagues, but it's excellent for families. You might say, oh, your kid's got bronchiolitis. That's when a virus that normally goes up here, like that, actually goes into the lungs and causes redness and swelling. And they're really trying to follow along because it makes sense. But they cannot have the understanding that we have day in, day out working in healthcare. So you say, your kid's got bronchiolitis, which is this? But if I was to describe this as mild or moderate or severe, and your kid is a mild, that makes a shit ton more sense to families, especially at 1 in the morning when they're tired and stressed. So I actually love the mild, moderate, severe for respiratory categorisation and for communication with families. The other way to measure it is, I will always, a resident or registrar or anyone asks me about bronch, I will always want to know what day the bronch is, because this is part of the monolith, this immovable object that is bronchiolitis. Day 2 and day 3 are the worst. Always are the worst. So if I've got a kid on day 1 of bronch, I know they're going to get worse before they get better, and that's how it helps me inform, is this kid going home? Are they staying in? What am I doing for this child to maintain safety? Or that day 4, great, the family's done the hard yards, so we're going to get better from now on. It took me a shamefully long time to realise when the hell is day 1, like when do you actually start the clock? It's when the urti becomes the lurty. They might have had a runny nose and a mild cough on Thursday, but they're sick in front of you on Sunday. So is this day 4, or is it not? In the history, there'll be a time, and sometimes you do have to ask, but in the history there'll be a time when you can say, was there a time when you actually noticed that chest was really working hard? Or was there a time when that cough just seemed worse? They'll always say yes. That's day 1. That's when you measure, not when the runny nose started, not when the sibling came home from daycare. It's when that cough or that work appeared. And that's day 1, and then you'll know when day 2 is, and then you'll know when day 3 is. Alright. So, this is a horrible slide. I've ripped it from one of my talks to med students because I always ask them what they want to do. And they always give me, oh, maybe a viral test, maybe a full blood count, maybe a chest x-ray. And of course, the answer is nothing. Bronch is bronch. Nothing changes. Bronch, we know what it is because the kid is coughing, they're wheezing, you put your stethoscope on their chest, there's crackles everywhere, and there's wheeze everywhere. It's a diffuse, lower viral respiratory infection. Nothing changes that. So no tests will change that. Of course, now with the proliferation of viral PCR tests, and you cannot get past the front door without one of those, without one of those tests, then of course the answer to now is yes. But if you're puritanical about it, it doesn't change bronch, so we shouldn't do viral tests. But I can't meet a kid without it. So no/yes on the viral one. Okay, if the kid's super young and febrile, of course a urine test is never a bad idea. All right, what to do? Guess what? Bronch is bronch. So nothing changes bronch. You've got a 6-month-old with wheezing, beta agonists, salbutamol will do bugger all. Steroids have been tried and do not achieve anything. Adrenaline has been tried and does nothing. Hypertonic saline nebulized could clear out some mucus and didn't change a damn thing. The Americans tried helium oxygen instead of nitrogen oxygen, what we breathe. It's a less dense gas and it might have gone down the airways better. It didn't. Nothing has changed bronch. The one thing that can help is nasal spray. Babies only breathe through their nose. So as part of being crook, they've got really clogged up nose, you can try and maybe suck out some boogers, or maybe spray some atomized saline up there, or put some drops down there, try and clear some mucus out, and then especially pre-bottle, and then they'll be able to get through it. What does work? If they aren't oxygenating, give them oxygen, and if they can't feed, give them feed or fluid. How do you judge that? It's 2 tiny bits in a slide, that's kind of the main point. How do you judge? So baby will be working hard, they're going to be raising their chest, getting everything that they can to try and move air up and down. I mean, my kid made me do these silly animations on my slides, so I can't go back very quickly. And he's like, I think that one's really cool. 4 seconds between slides, way worse. If you've got a bronchiolitic airway, and your diameter is down by half, so the radius is 1/2, this is an obnoxious question, not wine-worthy. What's your flow going to be? If anyone remembers Placille flow. What's flow up and down a tube relative to the radius? 4th power, that's right. 1/r⁴. So if your tube is half, it's now normal aperture. Your flow is 1/16. 1/16 of what you could normally breathe. So these babies are working like a bastard to get air up and down these narrow tubes. So your question is, are you getting reward for your hard work, mate? How do you tell if a baby's getting reward? What else are they going to do? They have to oxygenate and they have to feed. So if a baby can oxygenate, step 1, and if they can feed, well that's it. Because imagine how hard it is as a baby. You have got inflamed lungs, you are working hard to breathe up and down these bloody tubes, and we expect you to attach to a breast or a bottle and suck and swallow and digest all at the same time. It's impossible. So if your kid can do that, and by saying do that I mean roughly half of its feeds and half of its normal wet nappies, well then it's winning. If it's not doing that, then we intervene. How do we intervene? The nasogastric tube. Normally we'll start on roughly 2 hourly feeds. We don't want to fill the stomach up too much and stress the kid out. If even 2 hourly feeds is too much, we'll run it continuously over 24 hours. And sometimes that's too much. And then we swap to IV entirely. Alright. I'm over time. So I'm going to ditch my diatribe against high flow. I'm an ED guy, I'm not a general pediatrician too much anymore, so I can leave it alone. The giants, okay, abdo pain. We've all seen people with abdo pain. Abdo pain is 10% of pediatric ED's workload. The one trick with abdo pain is an intensely unsatisfying presentation. It's unsatisfying for the child, it's unsatisfying for the parents, and it's unsatisfying for us. Why? What we do know, because it's common presentation, is that if you take every physical objective investigation ever invented by a human being in a laboratory, every urine test, chest x-ray, MRI scan, CT scan, don't CT scan kids please, urine test, everything, you will find an answer. You can say to a family, your child has X half the time. Which means half the time you can do everything and there's never a bloody answer. And that is exactly what I tell parents because I want to lower their expectations of me. So this is the one time when you walk into a room or see a kid and you do not know what the problem is, because half the time you will not know what the problem is. You want to know what the problem isn't, and that's when you have the list in your head. Your list can go by systems, infective, surgical, weirdo, metabolic sort of stuff. Your list can go by geographic areas, that's quite cool. Or your list can just be this horrendous thing from up to date. When I was a junior doctor, I did print out this up-to-date article, read it twice through, front to back, and I haven't had to worry about abdo pain since, which is a very long time ago. But half the time you will never know. So if the kid doesn't have any really severe, periodic, neurological features, they're probably going to be okay. One of the things to think about is appendicitis. Why? I mean, it's a disease of teenagers and young people. It's got 8% lifetime prevalence. That's a lot of kids. And when you explain to kiddos, like, that's 8%, mate. That's like 2 or 3 kids in your class. That's 2 or 3 kids in every class, everywhere, ever, will get appendicitis. You draw a graph between the age of 10 and 30, peak age is 14, so it is a disease of young people. They will generally lose their appetite. They get the central pain that goes to the ref, all of those good things. And then they really do, the older the kid is, generally over 5, they'll give you the good classic McBurney's, all those sorts of signs. And even, you can ask them if you're very good, did the bumps in the car hurt on the way over? Which is a legit article, and legit won this Ig Nobel sort of famous prize. And in paediatrics, the classic thing is, can you jump? If they can jump, they can go home, even if it's appendicitis, because they will not need an operation until at least tomorrow. But appendicitis, it's true. So if they bumps in the car didn't hurt, they can jump up and down, come back tomorrow, mate, and see if you really have it or not. But it is common and it's worthwhile thinking about. Okay, the fever. This is the other big one. Abdo pain is huge. Fever is huge. Of course, it's huge. I was going to 5 minutes on this one, mate. Okay, so fever. Everyone's got a fever. What do we know about fever? It's ridiculously common. Teething doesn't cause it, by the way. Teething causes a mild physiological rise. Eating over 37.5, in my mind, is pathological. I know you guys are taught to be 38. It's a matter of debate. I'm on the 37.5 part of the debate. People hate paediatrics because kids are breakable, they're not really, and they can't tell you what's going on. Okay, that bit's true. But almost always there's a clue in the history. There's a runny nose. They started daycare last week. They're drinking liquids, but they're not touching solids. They probably have a sore throat or tonsillitis. There's almost always a clue in the history. The truly, massively undifferentiated kid is actually super rare. The history is where it's at. You just need a good history. What are the basics? Yep, good history and a bit of a report if you can establish it. What are the pitfalls? People come to PCD terms wanting to know how to recognise they're unwell or a well child. Yeah, that's a big thing. That's not real magic. It's just paying attention to the odds and the story. But how do you approach fever really? Divide the patients. Kids under 1 month, that's a nightmare. It's basically meningitis proven otherwise. They get the Worksburger. The Worksburger is IVs, admissions, IV antibiotics, needle into the bladder, needle into the back, every bloody thing. And again, that's a whole other talk by itself. Over 3 months, you're a kid. I always have to think about you. Hopefully you got a cold. 1 to 3 months, we used to be more conservative. Now we're getting a bit more relaxed. I can use my brain a bit, decide if you're sick or not sick. And if you look sick enough, okay, you get the Worksburger, no problems. Things parents will ask you. The fever was really, really high. Unless it's 41, I don't much mind. Over 41, still a over 50% chance of being viral, but meningitis numbers are creeping up over 41. Came on really quickly. That's been studied, it's not a thing. Didn't go away with Panadol. Bad luck this time. In fact, the current flu epidemic, Panadol doesn't touch the damn size of it. And they had a seizure. Don't worry about the seizure. Well, actually you do. I'll explain why and why not. The fever more than 5 days, that's always a thing. There's always a thing on fever more than 5 days. Should I do bloods? Should I do x-rays? Should I do everything? Fever more than 5 days is a thing. My argument is you don't have to do tests, you just have to think a little bit harder. Why? The risk of an SBI, serious bacterial infection, usually UTIs or pneumonias, is about 5%, bit over 5 in the other 5% group. The over 5% group, you're pushing 8.5, so it is far more common. And you can see why. Kids start off with a cough and a cold, they're getting over their first infection, lungs are a bit down, boom, pneumonia kicks in. So the fever, the cause of fever on day 6 is probably different to the cause on day 2, but it's all been an everyday thing. So you do have more problems. But really bad problems, like invasive bacterial infections, are still less than 0.5%. And the inflammatory and the Kawasaki is actually totaled up to about 2 on both groups, which is quite fun. All right, the febrile convulsions. This is another giant. Kids come in all the time. There's all these diagnostic criteria, and again, I wanted to go through them, but I've paddled on too long, sorry. So I'm just going to say take these one time. I don't take my slides. What's the main thing? It's the rule of threes. 3% of kids will have a febrile seizure. Same age range, 6 months to 6 years, PK 18 to 24 months, no problems. If the kid hits all the standard things like it's a brief seizure, the source of the fever is not in CNS, then they can go home, and there's no increased risk of brain damage or seizure. Atypical feature in times the risk of seizures, which is the standard 1% basic background, by 3. So what was 1 is now 3% if they had a prolonged post-ictal phase. What was 3 is now 9 to 10% if it's their second episode in the same illness sort of thing. What is really important for me, this is when I put my GP hat back on, is the family. If you ask one of my lovely ASIM colleagues will go, oh yeah guys, febrile convulsion, no worries, the kid's going to be fine to walk away from the parents are shattered, they're doing this. They've just watched their kid have a seizure for the first time. And if we ask them directly, what are you feeling? 90% of parents who just watched the kid have a seizure for the first time thought they were watching their child die. And that is honestly the most important figure in febrile convulsions. So how do I approach this one thing? I tell them, when asked, 90% of parents said they thought they were watching the kid die. They go, yes, that was me. I'm like, cool, totally get how that's a thing. Knowing that that's what you've gone through, how can I look you in the eye and tell you it's going to be okay? It's because, your kiddo has ticked every box. Because of the every box, all the standard statistics kick in, and we know from the standard stats that your kid's going to be okay. You've got to let them get that out, because on this thing about, yes, I thought I could watch my kid die, a third had insomnia, a third had anorexia. This is the parents of the kids who can't eat and can't sleep again because of how awful it is to watch. Alright. The very last thing I'm going to talk about is my favourite topic, which is starvation ketosis. It may sound silly, it makes perfect sense. Kid has tonsillitis, gastro, can't eat, can't drink. They've got pissy weak little livers, they can't maintain their sugar, they start burning fat. Get a little bit of ketones from fat burning, it's okay. Get more ketones, you have the symptoms of ketosis, which is nausea, pain, headache and dizziness. Half the symptoms they were sick with in the first place. So now you've got a kiddo who just will not do a damn thing and needs IV rehydration, except they don't. Now that we acknowledge that they're sick, just give them juice. Basically, juice outperforms Hygelite every day of the week. Much, I hate Hygelite as a PTD guy. Loathe it. Just get 1 glass of juice, 1 glass of water, put them together, throw them at the kid. They're going to clear their ketones, start feeling better, and they're going to go home with about a quarter the rate to a third the rate of IV or NG rehydration. So even if they're not vomiting, give them on dance. They're ketotic. They're going to be nauseated. Even if they're not claiming they've got a headache, they're going to have abdo pain and a headache because they're ketotic. So give them Nurofen, and then give them an icy pulp. We stopped stocking Hygelite ice balls in my ED. We just stopped juice ones, and our rates of admissions for just standard sick kids for IV rehydration have plummeted. So my absolute favourite is that I am going to go past all of my trauma, because I'm really sorry, and I am going to finish on everyone's favourite, which is wine. So my final question, and you guys have done very well to sit at the front and be residence registrars, so now you're stuffed. What happens when the heart pumps blood? As in, this is my question to you. How does the aortic valve close? Normal, in all of us right here, right now, our aortic valve. How does it close? One hand up, one brave soul. Oh, you got your fists up, good. No, you've done it, you've stepped on it now.
No, sorry, I'm acting out loud.
That's fine, I had to do the same. And I got this wrong when I first figured this out. Heart pumps, blood goes in the aorta, then what happens? Heart relaxes and blood goes backwards and the valve shuts. Everyone says that. Totally wrong. Totally wrong. Okay, I'll give you the next clue. What does the sinus of Valsalva do? It sits right above the aortic valve. What's it for? We all have it. Mammals have it. All mammals have it. I know, I just got this wrong too. It's great. The sinus of Valsalva is how the aortic valves close. All the blood that goes in the middle of the aorta goes forward, but it's this little curve at the end for blood to flow and eddy and push around and shut the valve from the sides. Modern tests have proven this, with MRI flow studies that have shown it's not the retrograde pressure. Every single person, including me, I've ever asked that question to, has got it wrong, so don't feel bad. You're taller than me anyway, so you should be feeling fine. So, the revolving impetus closes the valve for us. My question is, for the wine, who was the first person to figure this out? Me? No, not me. Okay, I'll make it easier for you. This is a modern fMRI study. This is the original person who figured it out, their diagrams. Da Vinci. Da Vinci figured this out at the start of 1500. He did dissections on oxen, sheep, cows, humans, saw the signs of salva in all of them, figured out it must have a purpose, made a glass model, because of course it was Da Vinci, and figured out that it was this 500 years before anybody else figured it out. He also figured out that the heart had 4 chambers that worked top to bottom. Again, no one else figured it out, so Da Vinci, well done. Alrighty, I have gone on, and I do apologise. I thought I had the timing on this one sorted, and I was wrong. Have we got any questions from this? Steroids, asthma, croup, bronchiolitis, Da Vinci, anything? Alright, I will be around this evening, especially after Lovely David's talk. If you have any other questions, my card's there if you want the talks yourselves, and I'll keep these one. Two fabulous people, you got all this right. Alright, thank you everyone.
Thank you very much, Mark. Let's take 5 minutes. Just a quick break tonight, just so we can make sure we're not rushing David at all. Apologies for those at the back who are still having some sound trouble. We're going to try and put the sound up a bit more. Tonight they're going to come in and put 2 new speakers at the back. So just at the front. Yeah, and then just as tonight, till those speakers arrive for tomorrow, there are lots of seats at the front. So feel free to move around after the break today. But we'll see you back here in 5 minutes.
Please, why are you joining? And you can't even read the screen. okay. Yeah.
Okay, everyone, we are going to make a start, so thank you all for the quick turnaround there. Just a real few quick ones from myself. So on the back of your lanyards, you'll notice there's a QR code. Sorry, it's not one of those like Oprah moments where you're going to win a prize or something like that. Makes people get excited. But that links to our info book, and the info book we put together to try and cover kind of all the frequently asked questions we have during the week. So lots of info on there. There's links to the e-learning. There's details about how you'll receive your certificate. There's a few ideas for day trips, how to get the 10% discount. The live streaming link's a good one on there if you're unable to make any of the sessions. So we are streaming live, but then also the recorded presentations will be via that same link. So that's up there for you guys to go back and have a look at any stage in the future as well. And that's the best spot to also look and pull slides from, as Bart was saying earlier. The other thing in there is how you can win door prizes. So we do have a number of prizes to give away this week, and the idea behind that is really to encourage you guys to get out there, take some photos, and share them with the group. So we already have 4 photos that have been submitted. It's a really objective way that we pick a winner. Pretty much we show some photos up, loudest cheers get the prize. So, we've got 2 prizes tonight, 4 photos, so a good chance you might be in for the win. So get ready to start cheering, get ready to start clapping. First photo. There we go, what do we reckon? Oh, I wonder who sent that photo through. Alright, that's the leader so far. Next one? Yeah, one happy camper. Oh, that's a bit pretty. Yeah, that's a good photo, but it's kind of hard when you're staring at you the whole time. And this one, hopefully it'll work, is a video, so let's have a look. They fit a lot in already, haven't they? Alright, that's worthy of a prize for sure. Alright, so the video submitter, and let's go, because it was a group that made the biggest noise, this photo as well. So congratulations everyone, big round of applause for everyone. So to check out the info book if you'd like to submit your photos. Pretty much all you need to do is tag us in social media. If you're not on social media or your account's on private, feel free just to send your photos through to our email and we'll get them loaded up. Hot tip, the earlier you submit them, the more chance there are of winning, because as the week goes on, the more and more photos we get. That's it from me now. So we'll get straight into our next presentation. If you do need to stand up and have a move around at any stage, please feel free to do so. You don't have to stay in your seats if you do prefer standing or moving. But let's make a big noise to our returning presenter, David Beaumont. Thank you, David.
Thanks, Quentin. Lovely to see you all. How are you doing at the back? How loud do I have to shout? These things here are called acoustic baffles. They're to absorb sound because this is a restaurant. So we don't want to hear each other talking, do we? So that's what I've got to compete against. Tell me if I'm not loud enough. Can I check? Who's here from Australia? Oh my goodness. Welcome to Queenstown, the jewel in New Zealand's crown. Who's here from North Island? Welcome. Welcome to Queenstown, the jewel in New Zealand's crown. Oh, I loved that one, didn't I? I actually came here on holiday in 2005 from the north of England and never left. And I'm sure, looking out there, you're not surprised to hear that. I'm actually an occupational physician. I'm a doctor who specialises in the health and well-being of workers. Yes, that's you. In fact, I consult to a number of New Zealand's major employers in all sorts of different sectors, but I am a national occupational physician to St John here in New Zealand. So I know a lot about what you guys do. Anyway, health, disease and healing in a system in crisis. Healing at an EMS conference. Bit of a strange word. Can I just check, actually, how many of you here are healers? Oh, 2, 3, 4. Cool. You guys can relax. The rest of you really need to concentrate. Okay, here's a question. How are you feeling about the system that you work in right now? How are you feeling about your role in emergency care? How many of you have experienced burnout in the course of the last 12 months? Symptoms? Come on, show of hands. Okay, I'm going 43%. Okay, thank you for your honesty. Why were you lying, the rest of you? I asked that very same question at a GP conference that I spoke at only 3 weeks ago. How many of them do you think said they were burnt out?
All the registrars, all fellows.
The vast majority. Statistics from the how do you say it? The Royal New Zealand College of General Practitioners is that 79% of GPs are feeling burnt out right now. I asked them another question. I said, how many of you do 10 clinical sessions of general practice per week? That's 5 days work, 5 days work per week. What percentage? Or what number? 4 or 14? 40. You were so close with 4. It was actually 2. There were 200 in the audience, and 1% did 5 days work. This is Ackworth in Yorkshire. It's a semi-rural village of exactly 8,000 people, and it has one general practice, and it's the general practice I joined in 1988. 3 full-time male partners, 2 part-time female partners. The full-time partners worked 5 days a week, 10 clinical sessions. We did 1 night in 4 on call, and we did 1 weekend in 4 on call. We never ever had locums, it was a rule, and we did all of our own cover and all of our own care. What has changed?
Well, if you're smart, you get locums to do some of your weekends. You changed the locums.
So we weren't smart because we didn't have locums. That's one interpretation, fair enough. Do you know what full-time general practice is now? How many days a week?
4.
3.5. 3.5. I mean, to be honest, they will do more administrative work on top of that. But if you do 3.5 days a week, it's classed as full-time. And of course, they might be doing a rota of shared on-call, or they might have opted out of on-call altogether. General practice has changed dramatically in the 30-odd years since in fact, I left general practice in 2000, so 25 years since I left general practice, it has changed dramatically. And I'm going to say that there are 2 reasons for that. One is that the complexity of our lives has changed since that time. And the other is illness has changed since that time. We saw 8 patients an hour. We had 7.5-minute consultations, and in that time, we would sort out the acute problems that presented to us. Obesity was not common. Diabetes was not common. Mental health problems were not common. Chronic disease per se was not common. Life has changed. The disease pattern that we're encountering has changed. Many of the chronic diseases have increased by up to 4 to 5-fold in the last 50 years. What if we're losing the war on chronic disease? Last week, the CDC in America revealed some statistics from research they conducted that said that 1/3 of American teenagers have prediabetes. Well over 50% of the American population have obesity or are overweight, and New Zealand is very, very close behind them. What if we're not keeping up with the complexity of modern life? How many of you have you got an iPhone or an Android or a smartphone of some kind? You got a smartphone? Hands up if you've got a smartphone. We've all got a smartphone, haven't we? When was the iPhone very first introduced? Say again? 2007, 2008, 2007. That's less than 20 years ago. Prior to that, we didn't have smartphones. When I started in general practice, we didn't have a computer, never mind an iPhone. Things have changed, and we forget this, how fast things are changing. But what if we're wrong about pathogenesis? What if we're wrong about how disease originates? This is really, really striking at the heart of who we are and what we do and what we understand. I am going to challenge you this evening. But what if we've forgotten about healing? What if we've actually forgotten that we are healers? This is me, shortly after 2000, I just left general practice. The British Medical Journal got hold of me and said, we hear you've just left general practice to become an occupational physician. Can you tell us about it? And I said, oh yeah, I absolutely love occupational health. It's amazing. Here I am, pictured. The caption says, David doing his dream job. And yes, it is me. I know the hair's darker and there's more of it. That was only 25 years ago. We forget how things change. So I left general practice to become an occupational physician, and something changed overnight. Overnight, I stopped prescribing. A doctor who doesn't prescribe. Occupational physicians in New Zealand, most occupational physicians around the Western world don't prescribe. We influence health by influencing the way that people deal with their illness or their disease or their challenges in life to achieve their maximum potential in life. Very different. But then something else changed on the 4th of November 2003. That's the depths of autumn in the UK. In the north of England, it goes dark by 3:30. It was a wet, miserable afternoon. I was coming home from work. And my wife called and she said, will you come and get some fish and chips on the way home because the kids are hungry. They were 9 and 7 at the time, and I got home with the fish and chips, and they were already sat at the table, and the plate of buttered bread and butter was there on the table, and I gave my wife the wrapped up fish and chips in newspaper, and I said, I'm just going to sit down in the lounge for a bit, and I'll be with you in a minute. And a couple of minutes later, she came in and she said, you don't look very good. Shall I call the doctor? And I said, no, call an ambulance, I'm having a heart attack. So the ambulance arrived very quickly. And I vividly remember some of the questions I was asked. I was asked to rate the pain. 8.5, I said. We'll give you something to help to ease the pain. I vividly remember going down the street in our village and seeing the blue lights reflecting from the houses that we shot past as I went into ED. And it's true, I'd had a heart attack at the age of 42 with no risk factors whatsoever. I was in for 9 days. No interventions, no nothing actually. They just stabilised me, angiogram and all that stuff. No angioplasty and no stenting, thankfully. I was only kept in because the local cardiologist knew me so well that he was making absolutely sure I got home safely and survived, and I did. And I was put on all the preventative meds, and I'm still taking them today. And here I am 10 years later, 2013. Any guesses where that is? Pub, near a beach. Pawanui is a good guess, but not right. I don't think there's a pub that close to the beach in Pawanui. Bay of Islands. This is the Duke, sorry, all these Aussies here, no idea. This is the Duke of Marlborough at Russell, on the beach, playing chess with a pint with my best mate in the world. I was taking all the preventive meds, but I'd actually done absolutely nothing myself. I'd done nothing to look after my own health and well-being, and I'm nearly 20 kgs heavier there than I am now. That's a very, very happy scene for me, but it's a scene that belies a great sadness, because what it doesn't show is at the time I was in the midst of a major depressive episode, that my marriage was failing and ultimately did. And in the midst of the dark night of the soul, I realized I had nothing to turn to. I had rejected the Christian upbringing of my childhood and spent my whole life as a devout atheist. I laugh now as I look back and realize I spent my whole adult life up to that point devoutly believing in nothing. And in the midst of the dark night of the soul, I had an epiphany. And I suddenly realized health is so much more than physical. Health is so much more than psychological. Health is more than our relationships, our emotional health. It has to be our spiritual health too, whatever that means for you. And that's when I realized that actually all of this is captured by the Maori model of health, Te Whare Tapa Whā, and actually by every indigenous model of health around the world, that health is multifaceted. It's about every part of our lives. And indeed, the whenua, the land on which the foundations of the house rest, is also important to us, with the way we relate to nature and the land and the environment. It's all our health. And I put this all together, and I thought, well, the Maori model of health is so important, and it gets mentioned in healthcare, it gets taught in healthcare, but nobody has actually operationalized it. Nobody's actually said, what would it mean to practice to this model? Yes, we do, we pay lip service to it, but I put the whole model together and I captured it into a concept of medicine that I called positive medicine. My son was a medical student at the time, and I told him about this, and he said, my son is the wisest man I know. And he said, Dad, that's fabulous, that's curing versus healing. I'm writing an essay on it at the moment. It's what they teach us at med school these days, you know. Now, I'm not sure if that's true or not to the extent that I had seen it. But what he said to me then affected me profoundly. He said, "Dad, I'm really pleased you're doing this. And if it only helps one person, and that person is you, then it's been all worthwhile." And it has been all worthwhile. And that's why I'm here tonight, to share this story with you and look at the implications, not only for medicine, but for you personally. So this is curing versus healing. This is actually from an amazing essay in the Canadian Medical Association Journal. I'm just going to read it so I get it right word for word. So curing is an action carried out by the healthcare practitioner to eradicate disease or correct a problem. Healing, on the other hand, is a process leading to a greater sense of integrity and wholeness in response to an injury or disease that occurs within the patient, but which can be facilitated by the healthcare practitioner. Curing is something what we do when we can actually take away a disease, which may be true in acute disease, but is not true in chronic disease. We don't cure chronic disease. We ameliorate symptoms, we slow progress, we don't cure it. Healing is what the person does for themselves. I captured all of this in a book. I called it Positive Medicine Disrupting the Future of Medical Practice. Yes, I admit it. I'm a disruptor. But I'm a positive disruptor. I'm doing this for the good of patients and doctors and everybody working in healthcare, because what we're doing right now ain't working. I got a number of emails once the book was published. One of them was from the chair, another name for president, of the Royal College of GPs of London, Professor Martin Marshall. He said, "Your book really resonated with me. You need to read my editorial in the BMJ. It's called Rethinking Medicine." Professor Marshall wrote in this editorial that modern medicine might be an amazing thing, but what if we're getting it wrong? Increasing numbers of doctors and patients and all manner of people are saying, yeah, you make wonderful claims for medicine, but what if it's not right? And what if what we're doing is creating nearly as much harm as it is good? And all these promises you're making about the wonderful advances in medical science, what's it doing for chronic disease? Bugger all. He said this critique is not new. This critique has been ongoing since the 1970s. In fact, particularly the 1970s. Excuse me, I'll have a slurp. The 1970s was very important for medicine. It was the year I went to medical school. And it was also the era of Nixon's war on cancer. Cancer would be a thing of the past. Billions injected into research into cancer. Within 5 years, cancer will have been cured and eradicated. We're still waiting. However, this was the heyday of medical science. I went to medical school as a scientist. And you perhaps can't read the plaque outside Sheffield University Medical School that says, Ars Longa Vita Brevis. I'm not sure that Mark's second bottle of wine was ever given away. But Mark, if it wasn't, prize for the first person to translate Ars Longa Vita Brevis.
Hours long, life short.
Thank you. The art is long, life is short. It's the first line of Hippocrates' treatise. We laughed at it. It it was very quaint and old-fashioned, describing medicine as an art. We were scientists. We were there to cure disease. That's what I was taught. What I didn't realize, what I didn't know at that time, was that medicine was under attack. Really, really, firmly under attack. Ivan Illich wrote Medical Nemesis, the Expropriation of Health. The first line of which is, the medical establishment has become a major threat to health. Whew. Everything in his book is captured within his title. Medical nemesis means the inevitable demise of medicine and doctors because of the expropriation of health. Expropriation of health means that people's ability to manage their own health was being taken away from them by the false promise of medicine and the pharmaceutical industry in collusion saying, don't worry about pain, we'll ease your pain. Don't worry about dying, we'll keep you alive. Don't worry about the problems of life, we've got an antidepressant or a benzodiazepine, 70s. All middle-aged women were prescribed benzodiazepines. I know because they talked about it around my dinner table. He said, you're getting it wrong. It was vicious. It's a really important book in the history of medicine, so important that at the 25th anniversary of its publication in 2000, the BMJ did a review of Medical Nemesis. 50 years after its launch in 2025, this year the BMJ did a 50-year review of Medical Nemesis. This is a very important book because every single prediction Illich made in that book has come true. Who's heard of the biopsychosocial model? I suspect most of you, I mean, it's so obvious that, I mean, it's definitely part of medical teaching. How many of you have read Dr. George Engel's original paper? I didn't think you would have. This is an angry paper. This cites what Engel was hearing as he went around medical conferences. He was hearing that you get people who've got symptoms, but you do all these tests and they all come back negative. It's obviously psychosomatic. That's nothing to do with medicine whatsoever. That's a social problem. Let's leave that. Even the psychiatrists were saying, we don't want anything to do with psychosocial problems. He said, we must be wrong. I see all these people in my clinics with abdominal pain, all the tests are normal, but it's impacting on their lives. How can we possibly say this is not to do with us? We need a new model to work to. Engel offered the biopsychosocial model as a new model, a new medical model to work to. He was saying we need to look at biology, yes, psychology, yes, the social side, the emotional side, and now we actually talk about the biopsychosocial spiritual model, because that needs to be incorporated too. Oh, suddenly we've got the Maori model of health, the indigenous model of health. Most importantly of all, for me, was 1979 and Aaron Antonovsky's salutogenic theory of health and disease. This is the textbook that I was never taught at medical school. This is the handbook of salutogenesis. What a how misnamed is that? That's hardly a handbook. I'm just going to tell you about Antonovsky's salutogenic theory of health. What he said was, rather than focusing on pathogenesis, what is the nature of this disease? What is causing this particular disease? we should actually look at why people stay healthy and how they heal. Let's not focus on pathogenesis, the origin of disease, but rather salutogenesis, the origin of health. And what's this business about you're either diseased or you're healthy? In medicine, we have this weird dichotomy. We even have cut-offs of blood pressure range or blood sugar range. And if once you hit 50, then you've got diabetes. But it's actually a continuum. And what he talked about was there's actually a continuum between health ease and dis-ease. And what guides our position on that is how we're coping with life. And some people are stuck at that dis-ease end of the spectrum, and they're just not coping with life. And at some point, that tips over into disease. But what if the disease that it happens to occur is actually undifferentiated? It actually might appear as diabetes, or it might appear as a heart disease, heart attack, or it might appear as cancer. What if that's the way that disease works? Not that you start with the disease and then you work out what's caused it, but that actually the disease is the end result of the way that we deal with life. We're dealing with life really badly at the moment because we're not coping with the complexity of it. He talked about health as being homeostasis and disease as loss of homeostasis. He's not alone in saying that, as I'll come to. What Antonovsky said was that where you are on that dis-ease spectrum is determined by something that he called the sense of knowing. And the sense of knowing determines the extent to which you're able to avoid or not life overwhelm. He said that there were 3 components to the sense of knowing. Comprehensibility, how understandable life is. I get this, I understand what's going on now. Now I can do something about it. And manageability, I have the self-belief to know what I need to do to tackle this. And meaningfulness, I know this is important. I know that my life has purpose and meaning. In other words, it all makes sense. I can do this and it really matters. So what is burnout in this context? Well, burnout is part of our life overwhelm. It's chronic low-grade sympathetic arousal, fight or flight, caused by a system in crisis. The 3 components, what we're doing just doesn't make sense. Secondly, I don't believe I've got the tools to manage this. And thirdly, I'm struggling to find meaning in what we're doing, what I'm doing. The GPs at that conference 3 weeks ago, most of them would have agreed with all 3 of those statements. That's why they're at burnout. And now we have this concept of moral injury. Have you heard of moral injury? It became really prevalent during COVID. Moral injury is that feeling, shit, we should be doing so much more. I wish I could do more to help this person, but there's nothing here. We don't know how to deal with this. We're getting it all wrong. And I'm taking this home with me and I'm not sleeping because of it. That's moral injury. So how do we deal with that? How do we deal with how are we doing? How do we avoid the life overwhelm caused by a system in crisis? Well, the starting point should be to change the system. I was leading a workshop of 30 or 40 GPs a few months ago now, and it was a full day workshop, and about half an hour in, one of the GPs put his pen down and said, why am I here on a Saturday morning working out what I need to do to look after my health and well-being, when the problem is the bureaucracy I have to deal with and the relentless patience with all their complex problems? Don't tell me to sort myself out. Sort out the bloody system. Somebody else chimed in, oh, I completely agree with you. All the bloody paperwork we have. Oh, yeah, soon the room was in uproar. So I thought, all right, that's it, I'm going to join in. Yes, you're right. Let's change the system. Let's tell them. Who are we going to tell? And what are we going to tell them to do? And how long is that going to take? Okay, why don't we agree to control what we can control, and to accept that there are parts that just aren't going to change in the time frame we'd like them to. He picked up his pen and he said, carry on. So we're not going to change the system quickly. So what we can do is to make sense of what's happening, to find the self-belief to actually deal with what's in front of us, to face the challenge of the system that isn't working and make the most of what we've got, but most importantly, to find out what it means to us. What does it mean to you? Let's see if we can make sense of it, but using Antonovsky's framework. So I did say that he wasn't the only person saying that health is homeostasis and disease is disrupted homeostasis. This is Professor George Beaumont in 2020. This is an amazing paper. Wonderful, wonderful review of the history of homeostasis, the underappreciated and far too often ignored central organizing principle of physiology. Don't know about you, but I was taught about homeostasis in the first few months of medical school, and it was never mentioned again. Homeostasis has actually been described as what defines life. All living organisms have homeostatic mechanisms. And actually, this leads on to the fundamental questions of medicine. What is health? What is disease? And what is healing? Questions that were never answered for me at medical school. It's taken me 20 odd years to come up with this, but here it is. Health is homeostasis, disease is disrupted homeostasis, and healing is restoring homeostasis. Ta-da! Let's use the example of type 2 diabetes. Homeostasis, in terms of blood sugar, is a fluctuation between, 4 and 8 after a nice carbohydrate meal, and then it goes back down to 4 and hovers around 4 or 5. And you'll note the word homeostasis. It doesn't mean that it's kept at in the same state. That would be homostasis. It was deliberately called homeostasis, which means similar state. It's allowed to fluctuate between certain parameters, but it's kept at that level by feedback and feed-forward mechanisms, very complex interconnected mechanisms in our body. This is what happens when it goes awry. This is a trial of N=1, sometimes known as a case study. I'm slightly embarrassed to say this is me. Diagnosed in 2015, 13 with pre-diabetes with an HbA1c of 42, and my GP said, we'll have to monitor that. And these are the results up to 2023, when my HbA1c was 47, and my GP said, we'll have to monitor that. And I thought, what? Wait, why aren't we doing something? Let's do something. And all that time, I thought I was living pretty healthily. But then I suddenly realized, oh, for sake, he's waiting till I get to 50, and then he can say, congratulations, you've got diabetes, we can put you on metformin. And I just thought, oh, stupid me. What have I been waiting for? So I went to see Dr. Glenn Davis, who had just been made GP of the Year for his work reversing type 2 diabetes in 150 of his patients in Taupo. Can I just check, how many of you here have heard of the concept of reversing type 2 diabetes? I'm going 15%. I'm not surprised, but I'm sad, because there are now groups of doctors around the world who are very, very successfully reversing type 2 diabetes. When I say reversing, I mean patients on multiple oral medications, and that's failed, and we've got you on insulin, and we'll actually, do you know what? We're going to reverse it. We're going to put you on this regime which will reverse your diabetes and get you off all medication. How long do you think that's going to take? 6 months. 6 months. Any advance? How about 8 to 12 weeks? How about a minimum of 7 days to reverse type 2 diabetes? So Glenn's telling me all this. He spent an hour with me, bless him. What a wonderful, wonderful guy. He just said, you need therapeutic carbohydrate restriction, you've got your calorie intake is in excess of what you're burning off, but we've got to shock your system into restoring homeostasis. We've got to get you back on track. Don't worry about it. We've got a health coach. She'll help support you do it. I'm sure this isn't going to be a problem. And I believed it. And 3 weeks later, I had reversed my pre-diabetes to 40. 6 months later, it was 34, and incidentally, I'd lost 10 kgs. I say incidentally because it wasn't deliberate. It's just what happens when you actually have fewer calories intake than you burn off. Weird, that. I know. Let's just add some science into this. Let's add some new science. Here we go. Psychoneuroimmunoendocrinology. Let's just call it neuroscience, but actually everything is in the name. Psychoneuroimmunoendocrinology says that our thoughts influence our nervous system, influences our immune system and our endocrine system. Again, weird, but even if we think scary thoughts, we can put our system into sympathetic overdrive, particularly if you're a person already in a state of hyperarousal. And then you start releasing cortisol and adrenaline, and your heart rate goes up, and suddenly your whole body is reflecting what you were thinking in your imagination. It's all there. And this has been captured in great detail by Stephen Porges in his polyvagal theory. And what he says is, we heal only in a parasympathetic state. We can only be in a parasympathetic state when we feel safe. I was taught at medical school the sympathetic nervous system is fight, flight, or freeze, and the parasympathetic nervous system, whoops, there we go. And the parasympathetic nervous system is rest, digest, and restore, or rest, digest, and repair. That's the healing bit. I was taught at medical school that we heal in a parasympathetic state. We've now got some amazing science around the mitochondria. Again, I was taught about mitochondria in the first 6 months of medical school and never again. The mitochondrion is actually the heart of the cell. It actually controls a lot more of the cell physiology than we actually realize. But of course, it is also the powerhouse of the cell. It's where nutrients are processed and turned into ATP along the electron transfer chain, except when you're in a state of fear. When you're in a state of prolonged fear, your cells have got an evolutionary mechanism and they shut down. And the mitochondria go into slow mode. They tick over. It's self-preservation and it's meant to be short-lived. But if you've got ME/CFS, your mitochondria are switched off long-term. Robert Navio says this is the mechanism behind ME/CFS, but it's also the reason why all chronic diseases are associated with fatigue, because of mitochondrial dysfunction. Every chronic disease, research says, has mitochondrial dysfunction at its heart. They're not teaching that at medical school yet. Just you wait, another 30 years and they will be. So, we have a mechanism why life overwhelm leads to chronic sympathetic arousal, neuroendocrine dysfunction, the cell danger response that Navio describes, mitochondrial dysfunction, cortisol resistance, immune dysfunction, with chronic inflammation leading to dis-ease. ME/CFS is a dis-ease. It's an illness with no pathology attached, but it could result in disease, chronic disease. What Antonovsky didn't have in '79 that we have got now is food overwhelm. Food overwhelm causes metabolic overload, metabolic dysfunction. Guess what the mitochondria do when there is food overwhelm? They shut down. They go, what the hell am I going to do now? I've got all these nutrients. I know. I'm going to stuff it in the liver. I'm going to convert it to fat and stuff it in the liver. Liver's full. They've got fatty liver. Over 50% of the adult population are reckoned now to have fatty liver. Let's stuff it in the abdomen, in the peritoneal cavity. Let's bang it all in there. The omentum, a great reservoir of fat. Mitochondrial dysfunction. All of this leads to obesity or diabetes, and or heart disease, and or dementia, which is now being called type 3 diabetes because of the associated insulin resistance. Cancer or autoimmune disease, mental illness, all the same mechanisms. There are over 100 autoimmune diseases. When I was at medical school, they were called idiopathic. Graves' disease and Hashimoto's, they'd identified antibodies. Type 1 diabetes, they just identified autoantibodies, but now we know all of these to be autoimmune diseases. Autoimmune diseases are currently increasing in both prevalence and incidence by between 10 and 15% per annum. We've got massive increases, and in some of these, particularly in women. Autoimmune disease is simply immune system dysfunction. It is simply disruption of homeostasis in the immune system. So what is healing? Restoring homeostasis. How do people heal? By avoiding overwhelm and chronic sympathetic arousal. By feeling safe. By achieving emotional regulation and a predominant parasympathetic state. 80-20 rule applies. We used to spend 80% of our time in a parasympathetic state and 20% in a sympathetic state. We have absolutely reversed that ratio in modern life. And we need to restore mitochondrial function by switching off the cell danger response and reversing food overwhelm. And when we do, healing can happen quickly. So what is the role of emergency care? Are you curing or healing? Well, you're not curing because you're not taking away the disease. You are doing acute management, but in the vast majority of cases that you deal with, you're not going, da-da, go home, you're cured. You're go home and see your GP. What you're doing is actually the restoration or maintenance of homeostasis. I was talking to my very good friend here in Queenstown, who's a physician, and he said, yeah, homeostasis in chronic disease, kind of get that, but yeah, if somebody's got an acute MI, you're not trying to restore homeostasis. Oh, fuck, you are. That's exactly what you're trying to do. You're trying to restore homeostasis. You're also helping them avoid overwhelm. By your very approach to them, you're reinforcing their ability to emotionally regulate, and you're providing them with a safe haven just by your presence. I put there, you're limiting the impact of the cell danger response. You're definitely not helping them avoid food overwhelm, so I might be pushing it a bit with that one. But you are definitely having an impact on healing. What can you do to help to manage your cells in this situation? Here's the 3 R's tool for emergency care. Regulate, relate, restore. Recognize your own ability to emotionally regulate. That doesn't mean stay calm all the time. It doesn't mean that you've got to remain in a parasympathetic state, but aim for 80-20. If your adrenaline gets ramped up, make sure you take time to just calm down. One tool to do that, 3 conscious breaths. Long, slow pause. Pause on the exhale. Why? Because of sinus arrhythmia. When we breathe in, our heart rate increases because we increase sympathetic tone. When we breathe out, our heart rate slows because we increase parasympathetic drive through the vagus. Longer exhale than inhale. Just 3. You'll be amazed how calming that is. So regulate, emotional regulation is about learning how to balance sympathetic and parasympathetic. Relate. Your presence counts. You are making a difference. You're helping them feel safe by your presence, by your emotional regulation. Celebrate that for yourself. Celebrate that with your partner. Celebrate that with your colleagues. And restore. Don't forget your own needs. Don't forget to make sure that you are finding time to rest, recover, recuperate, fill your own cup. Those are the 3 questions. Does this make sense? I know I've stretched your thinking today. I know that I've taken you far further than you thought you would be doing on a conference in Queenstown. But does it make sense? Even bits of it. If even a bit of this is true, we do need to do what Professor Marshall says, and we do need to rethink medicine. How's your own self-belief? Are you able to face your life, face your work, and say, I've got this? And is what you're doing meaningful to you? Do you know what your purpose is? Do you know why you're doing what you're doing? Take some time to reflect on that. I suspect that you can say, this makes sense, I can do this, and it matters to me. The system is in crisis, and it's going to remain so for some time to come. You are the system linchpins. You are, believe it or not, the first step in healing. Actually, you're all healers. We all are. We're helping people to help themselves, to heal themselves. I just want to say thank you for everything you do, and I just want a round of applause now because I'm finished. And the round of applause is for you and everything you do. Thank you.
And a big thank you to you, David, and also Mark for his wonderful presentation earlier this evening. At risk of sounding like your parent, it's time to get an early night because we have a big morning planned for you guys tomorrow. We have 3 great presentations. We have Mark coming back talking about acute communication. We have a case study on paediatric drowning, and then we also have a look at ONG in the acute settings. So early night, come in nice and fresh. We'll have lots of coffee available. It will be a 7:45 start, and because we do have those 3 presentations, we will be trying to start at exactly 7:45. So enjoy, have a great night, and we look forward to seeing you all tomorrow. Thanks all.